All right, thank you very much. Our next team of presenters, I am so pleased to be able to introduce to you their local friends. They've presented to state and national audiences on the benefits of developing a safety huddle, and so I'm gonna introduce them to you and welcome them to the stage in just a moment here. Our first speaker is Donna Crimmins-Bunnell. She is the Director of Quality Services at Methodist Mansfield Medical Center, which she joined in August 2010. Her experiences range from critical care to Chief Nursing Officer and quality and patient safety. Donna lost her dad due to a medical error, and that is the reason that she has such a passion for patient safety. She's been honored by the community and her peers for her work with quality and safety by being recognized as a Dallas-Fort Worth Great 100 nurse and by the Fort Worth Business Press as a healthcare hero. Co-presenting with her today is Dr. John Phillips. He is the president of Methodist Mansfield Medical Center. He began his healthcare career as a UT Southwestern trained physical therapist, where he was blessed with a passion to pursue quality improvement and creating a safer environment for all of us and our patients. Please welcome with me Dr. John Phillips and Donna Crimmins-Bunnell.
Good morning. Thank you all for having us today. What a great event. You know, kudos to the Dallas-Fort Worth Hospital Council for arranging this two-day event. I'm in awe of being here. I think my only regret thus far is Dr. O'Connell set the bar really high. It would have been nice to go first on the agenda, so how about another round of applause for Dr. O'Connell? You know, several things that Dr. O'Connell covered today. I think there's hopefully some overlap in what Donna and I get to do today, which is share our experience with implementation of what we call at Methodist Mansfield Medical Center our daily safety huddle. So we'll talk a lot about that. Donna and I will go back and forth this morning and describe what our experience with a safety huddle is. You know, I'm in awe of people who have a bucket list, and I guess in my life I'm creating a bucket list. I feel like I'm going about it the wrong way. In creating it as I go, I feel like I should have one, a complete bucket list. I have a teenage son. He's 15, and he's this aspiring musical artist. So imagine what life at my house is like. There's a drum set, there's a tuba. I'm not sure where that fits in. And then there's electric guitar and now a bass guitar at our house. So anyway, I guess being around him, on my bucket list now is I would love to stand in front of a group and be like the lead singer for a rock group. Wouldn't that be awesome? But in all seriousness, I think today may be that event for me because look around the room and look who's here today. To your left and to your right are people that are passionate about patient safety. And in healthcare, and as I listen to Dr. O'Connell this morning, that's pretty close to a group of healthcare rock stars. So if you hear one or two things from me today, I hope one thing that you'll take away from today is your role and your power in ensuring patient safety at our hospitals, at our clinics, whatever settings that we serve in, our home health agencies, our post-acute care continuum, that it is the safest for our patients, and it's getting safer every day. One thing I've learned from Donna, and that's a real treat today, you'll get to hear from a rock star, just like Dr. O'Connell earlier when you hear from Donna this morning. I'm kind of the lead act, I think, in this whole deal, is the power that we all have in impacting or affecting change. So I hope you feel that, and I hope you feel that energy and that passion today. I want to tell you on our next slide a little bit about our hospital, Methodist Mansfield Medical Center. And so our next slide, I believe we have a rendition of that or a picture of our hospital. Well, we're doing that. Donna's got it?
No, I'm not sure that I
Here we go. Okay. So this is our hospital. And I wanted to share a little bit about our hospital so you could put what Donna and I are going to talk about today in some sort of context. But Mansfield, Texas is a suburban community of Dallas-Fort Worth. For those of y'all that live in the area, you may know where Mansfield is. It's just south of Arlington. It's kind of a place where the Metroplex is growing south, in between Dallas and Fort Worth and south, between down 287 and Interstate 360. What you see is our hospital as it will be in November of 2015. We are a 168-bed hospital. We're adding the second patient tower currently. It will be done in November of 2015. That once that tower is fully built out, we will have the capacity for 286 beds at our hospital. And I share that with you a little bit because I know we come from all different types of backgrounds: large hospitals, small hospitals, medium-sized hospitals. And as a president of a hospital, it was probably 2 years ago when Donna and others introduced me as the administrator of our hospital to the concept of a daily patient safety huddle. And I'm probably going to confess some things this morning that Donna may not know, but one of my original thoughts was, well, we're 168 beds. We run pretty full usually, but we're not big enough to do a daily safety huddle. We don't have those problems. Those problems are for the 500-bed or the 1,000-bed hospitals. And so that's a fallacy that was, by the way, quickly put aside as we implemented daily safety huddles at our hospital. So this is who we are. We have a neonatal intensive care unit at the hospital. We deliver about 2,000 babies a year in a growing suburban area. That's one of our leading service lines. In our emergency department, we see about 50 to 52,000 emergency department visits per year. Have an intensive care unit, of course, surgical services, a strong cardiology service line with open heart surgery, and we are now a primary stroke center as well. So I share some of that with you so you know kind of our scope of services at the hospital and what we were encountering, or kind of who we were as we started Daily Safety Huddle. On the next slide, we have our objectives. There we go. If I'm supposed to cue slides differently, someone just tell me. All right, I'll do a little body movement. I'll let y'all read through the objectives of our talk today. I'm reminded of this. My aunt, she's a college professor, and she was the person when I was a senior in high school. She gave me Stephen Covey's book, 7 Habits of Highly Effective People. And I sat down with it quickly and read it intently for 5 whole minutes before I put it aside as an 18-year-old. But the one thing I remember is begin with the end in mind, right? So here we go. This is 3 things that we hope you take away today is why we felt like, what we felt like the purpose of safety huddles were. I'm describing at least 3 ways that safety huddle could impact patient safety and your culture of safety at your hospital, and that you will also identify opportunities in your organization for a safety huddle. I've also learned that there's multiple ways to perform a safety huddle. Everybody's a little bit different. Every organization's different. So what Donna and I are describing today is our experience. And I think we would both agree that our safety huddle has evolved, and it will continue to evolve to better meet the needs of our patients as we improve our safety culture. And I'm going to throw Donna a curveball real quick. Donna, would you go one more slide, and then I'm going to bounce back to this slide. Okay, so what I wanted to do is just describe to you all what we do today in safety huddles. So this is just kind of a general slide that I'll walk through briefly, and then we'll go back to the previous slide, and then I'll turn it over to Donna for a few minutes. I guess it's been 2 years ago, almost probably to the month, that Donna approached me and said, I've got this idea. We've been Donna had been looking at and thinking about, and actually in partnership with our hospital engagement network, looking at starting a daily safety huddle. And so, it took us about 5 months or so of research before we ever started. And so that's probably a lot about me. I do not like to jump into things without really knowing what we're going to get into. So maybe I took longer than we should have taken to look at what the impact of a daily safety huddle would be, but I think what Donna and I agreed on is we didn't want to start too quickly and have a false start, start something that we couldn't support. So we took about 5 months to research what a daily safety huddle is. We actually listened in to other hospitals. There were 2 other hospitals that we were connected with, one in Texas and one out of state. And on several occasions, Don and I dialed in and listened to their huddle and to learn how it went, what the dialogue was like, and what some of those benefits were. So in December of 2012, December of 2012, it'll be 2 years this December, actually, we started our first daily safety huddle. And so this is how we do it. 5 days a week, and I think we can say 100%, for the most part, 100% of the Monday through Fridays since December of 2012 at 8:30 every morning, I lead a daily safety huddle at our hospital. If I'm not present at the organization that day, if I'm on vacation, if I'm at the corporate office for a meeting, off-site speaking to a group of rock stars at a convention center, then Donna, our quality director, will lead it, or our CNO, who is not here today, just finished probably 45 minutes ago, or 30 minutes ago, leading our daily safety at the hospital. We do not do our huddle on weekends, Saturday and Sunday right now. Some of the organizations that we've networked with have started their safety huddles on Saturday and Sunday. We're just not there yet. I've had several people ask me, do you plan to do that at some point? And I think going into this, I believe that we would at some point start huddles on the weekend, but we're not there yet. And we may get there sooner than later, but today we still do Monday through Friday. You see the time, 8:30 to 8:45. And was there anything else on there, Donna?
No. Let me, I think I didn't go the right way.
You're fine. There we go. And let me talk about who attends real quick. So 8:30 to 8:45 every morning, Monday through Friday. Every director or manager of a department at our hospital participates in the huddle. What we decided to do was we wanted everyone to come and be on site in the same room to have a standing meeting. And we do supply a dial-in number, a phone-in number, if a director, manager, or leader or their designee is not able to make it to our meeting room at the hospital. There is a number, a conference call number, they can call in and report for their department via phone. And again, we talked a little bit about who leads the daily huddle. So some benefits that we've realized so far of daily safety huddle are listed here. So a little bit about the call, and if we have time this morning, we'll actually listen to a few minutes of one of our actual calls and how it works. But I start the meeting, and we have a list that Donna will show you in a minute of just a roster of departments that report every single day. And so that's evolved over time as well. I initially thought, well, we'll have 30 or 40 departments reporting. Well, that's a 30 to 45-minute meeting usually. So we do have a shorter list of those departments that we've prioritized that report out every morning at Huddle. And the thought is what they're reporting out, or the training has been, what they report out is what has happened relative to patient safety the previous 24 hours, and what are they anticipating in their department that could be a patient safety issue in the coming 24 hours, okay? So it provides great real-time communication, and I was amazed when we started this in December of 2012 on the things that the administrator of the hospital, was learning that I never knew before. I didn't know before that, for example, that the CT scanner, one of our 2 CT scanners, went down the previous night. It was going to be down today. We had contacted the vendor, and they were hopefully going to be on site within the next couple of hours, but today we were going to be running with only 1 CT scanner. And that is important because as I look back, as an example, I would think about, before starting daily huddles, that's something I probably would have found out about if a physician would have called me from the emergency department and said, what's going on? Why are things so delayed? And that's how I would have found out about it before, but now I knew about it going into the day, and I could be proactive in my communication. Another measure, I think, of success is it's so fun to hear all the talk before and after our 15-minute huddle every day. Communication between directors, managers, leaders of departments. What they're finding, or what we're finding, is it provides that in-room meeting where they all show up and we meet together. It does provide them a forum to solve problems early in the day, forces that face-to-face communication. My teenage kids think I am the oldest, most fuddy-duddy person on the planet because I'm all about texting, but I'll call them during the day and say, hey, in response to one of their texts, and they're shocked. They're like, why are you calling me and talking to me? Why are we having actual one-on-one conversation, you know? And I just love that. You know, there's so many things that get lost in email that we can fix more quickly and address more quickly when we have that time every day where we're together for 15 minutes. Leadership awareness, I kind of touched on that. Problem identification and resolution and improved teamwork. I think Don and I will both hit on a few more examples of that as we go forward. Proactive approach to prevent harm to patients. Okay? Dr. O'Connell, I think, hit on many examples of that in our organizations as we improve patient safety, and our daily huddle has definitely contributed to that. And a culture change, one of accountability and one for transparency. So we'll hit on a few more examples of this as we go forward. Don is going to show you now a couple slides, and some of these slides will be small font and a lot of information. That's somewhat by design. It's not necessarily intended for you to see everything on the slide, but it's some of our forms that we actually use that Donna wanted to speak to.
Good morning. One of the first things that John and I struggled with is that we did have a couple of members of the C-suite who weren't quite keen on us kicking this off. With one of them, they felt we already do a daily bed board, and so this project that John and I were going to kick off is going to be redundant. How many of you out there's a spotlight, so it's hard for me to quite see, but how many of you currently do some type of a bed board or a leader stand-up or something in the mornings? Can we see a show of hands if anybody is doing that? A few people over here, a couple of people over here. So we face the fact that our leaders, two things. One, you're redundant by doing this, and the second thing is, are you checking up on us? Wanting us all here? Well, no, really, what we wanted to show was this isn't redundancy. I have asterisked all of the departments on here that you will see participate in bed board. If you'll take a look at those asterisks, it's mainly a clinical department, correct? And it's probably only 27% of the departments at the facility. 27%. So how do we effectively communicate when we have less than a third of our leaders at bed board? So that was one of the eye-openers. I think when we put it on a slide like this to the leaders, they're like, oh. And people are like, well, is IT really that important to bed board? Is the medical records department really that important? Well, you know what? They all are. The previous speaker spoke to the fact that we're all people and we have equal importance, and that's how I feel. It doesn't matter what department you work for, we all have equal importance. So we brought the team together and we actually did a slide presentation, an education session with them first, and this is one of the things that we showed them. In addition, the second thing we talked with them about is I gave some topics for each department and what they could think about at a safety huddle. And so when you look at the topics on the left of what's covered at a bed board, then you look at the topics on, well, it's my right, your left, of what's covered at a safety huddle. Do you see the disparity between the two? Which do you think has better communication impact? The safety huddle topics. So I asked a question earlier, do you think IT is as important? Well, our IT department is indeed on the call, and at times they're in the safety huddles. They would come to every Tuesday safety huddle. We underwent CPOE this past year. Is anybody on CPOE or been part of an organization when they first came up on CPOE? Do you think it went real smooth? Do you think there were opportunities to settle not only on a daily basis, but maybe on an hourly basis? We were able to help capture some of those opportunities at Safety Huddle. At Safety Huddle, IT was present. Their team who brought CPOE on board after all of the education, the day we went live, they were at Safety Huddle. The first week, they were there every single day, and they brought their problem list. So that was a very quick, real-time opportunity to talk about what we were experiencing and what we could fix really quickly.
You know, something that's become part of the norm of our culture, Donna talks about IT, and I think we're just starting to take it for granted, but Donna's positioned IT to report out as one of the last departments that reports out every morning. And what happens is, and this happened just this week, pharmacy, they'll report up, you know, kind of towards the middle of the list, and pharmacy said, well, our printer's down, it's not printing, okay? So we've been we put in a ticket at the help desk, it's 8:30 this morning, and, you know, hopefully it'll get fixed this morning. Well, Scott, our IT guy, he's down at the bottom of the list, so in about 4 or 5 minutes, it comes to Scott to report. What do you think Scott says now at Methodist Mansfield? Scott says, hey, I checked on that pharmacy thing, you know, so-and-so's coming to fix it, or we already have another printer on the way. And when at the end of that 15 minutes, that's a different culture. You know, when our team, when our clinical and non-clinical leaders hear a department that is being that proactive and responsive, and it's because of that real-time communication in the morning, something changes with your culture, and it's better. It is a better culture.
So that's really one of the main purposes of Safety Huddle, is to drive that safety culture. Safety culture does not happen overnight. And if we just say we're going to be an organization about safety and we don't drive it and truly hardwire it every day, which is what we try to do at Safety Huddle, then you're really not going to be changing that culture. And we'll show you some details that we have now been able to show how our culture has changed as a result of initiating the Safety Huddle. So some of the possible topics then is, I'm going to have to step back here to look. By the way, these are in your handouts, which you can download online, and it'll make it easier for you to see it. Miscommunication among the caregivers. Have you ever had a patient come up from the ED, go to the floor, and the floor doesn't feel they've had an adequate handoff? Happens. Someone over here said, all the time. It did happen in our organization more often than we wanted to see. But you know, once we started discussing that at Safety Huddle, that director is on that line, or in person, we can go immediately right back to the nurse, and there's a coaching opportunity. When we first started the Safety Huddle, one of the concerns was it's a blame game, and that is not what the huddle is about. It is truly about transparency and communication. When we have communication, we are respecting each other. So communication is key to respect, and communication is key to improving patient safety or preventing harm. Another interesting one is that patients with the same name, do any of you in your hospitals have patients who come in with the same name? Every morning in Safety Huddle, every unit has to talk about, we have 3 patients with the same name, we have 2 patients with the same name. One time we had 5 patients in the hospital with the same name, and guess what? That name was not Smith or Jones. Same name. So one of our things when we talk about same name, we have same name alert. We say the room number and the patient's last name. Because at the Safety Huddle, you have lab. Guess what? They get to go right back to their employees and say, today on 5 East, we have 3 Harpers. Today on 2 East, we have 2 Thomases. And you can give the room numbers. The second thing to me is the key, though, is that that caregiver is to go to that patient during admission process and say, today we have 2 Thomases on our unit. Please help us keep you safe by making sure every time we ask you your name and your date of birth and check your ID bracelet. Before we give you a medication, do a procedure, take you for a test, do anything. Every time we ask you, help us keep you safe. And at the beginning of safety huddles, people were like, okay, okay, okay. But when you constantly ask, as the leader, did we educate the patient? We are now at a point where in safety huddle, the leaders will say to us as we are running the safety huddle, they'll say, and yes, our patients have been informed. Yes, we have educated the patient and or their family, because sometimes you can't, the patient cannot participate in the care, but the caregiver's family or the families of the patients can. Sometimes they do come in with their personal caregivers.
And I was one of the people early on in safety huddles. I was so excited to know that we were sharing information about, okay, we have 2 patients in the hospital with the same name. I was so elated with that, just knowing that information. But what Donna just said was key. What we have learned and what Donna has taught us is, okay, once you know that and have that information, you have to do something with it, right? And that was a huge learning for me. I mean, one would think that's common sense, go do something with it. And I think a mistake would be early on in safety huddles not setting the culture of, okay, we have this information, what are we going to do about it? It's a fallacy to think, as common sense would say, that just because we know there's 2 patients in the hospital with the same name, that just saying that at safety huddle is going to magically keep those 2 patients safe, right? So what we've trained ourselves to do is just what Donna said. Now let's go do something about it. Have we educated the patients? Do they know what's going on so they can participate in their care?
One of the other departments that attends, which is very important, and they would never have attended bed board, is our security. We are fortunate that we actually have police officers. It's not a security division, but we actually have police officers who are on staff with Methodists. With the entire Methodist system. So they attend and they can talk with us about any incidents that went on to help our staff become safer. Leaving cell phones around nurses' station is one of the keys that we're talking about right now. But they talk with us about disruptive patients, how to keep ourselves safe, but in addition, when we had a forensic patient come in and hit the floor, one of the first words out of our police officer at the huddle was, we were not aware of that. So what we realized is, as we asked the question, our staff were not always aware of our policy when a forensics patient hits the door. So it gave us an opportunity to address the policy with all of the leaders. They then could go right back to their staff that morning and address the policy. For the next several huddles, whenever a forensic patient hit the door, we could ask that question, did you notify the police? Because in our organization, police and house supervisor get notified immediately if we have a forensic patient. At that point then, our police takes over to make sure that that forensic patient is as secure as it needs to be and our staff are as safe as they need to be. That huddle is what allowed us to hardwire that process that we would probably not have realized. Those patients sometimes were coming and going and we didn't even realize in the C-suite that that was going on. So you can see that the safety huddle really covers more than what a bed board would cover. Bed board used to cover, and it still does, staffing, how many patients are on the floor, what does our night shift look like, any falls, any core measures that are needing some updating. Well, that information, as you can see, is not the information we have already shared with you this morning on what goes on in a safety huddle. So those are some of the differences. One of the things that I was really proud of one day is we got a quick alert from our smart pumps. And during that alert, it said that please check your smart pumps for this particular little screw, that if this screw makes its way out, which it tends to loosen and makes its way out, then it will bend or break the little plastic shield that prevents the pump from free-flowing. And evidently in the country, this pump had been found in some NICUs to free-flow, and you know how devastating that could be to a patient. We were able to, in Safety Huddle that morning when it came over, our biomed was there. They were not going to be able to get out. They were going to come research all our pumps, a week later. We said, no, that's not acceptable. This is saying it could free flow. Right there in Safety Huddle, a couple of nurses with one of our materials managers said, we will check today. And every single pump in that facility was found, checked, and guess what? We had at least 5 pumps found, couple in the NICU that had cracks in that little piece of plastic that was known to cause free flow. We prevented very rapidly any issues that we would not have known about in the quality or risk department until the issue had already happened, until we already had a poor outcome for a patient. So this is how quickly you can act on communication. The next thing I want to show you is what our daily report looks like. So every morning, this is the form, and all of the managers and directors have been shown this. They know pretty much the list, where they fall in the rotation, and it starts with the house supervisor. One of the things in the huddle is we talk about what has gone on safety-wise in the last 24 hours, what do we anticipate today, and what do we anticipate in the next 24 hours. Those are the 3 things that we look at. So we run down, we look at how many patients we have on every unit. That's the first thing that the house supervisor gives us. Very quickly then, we do have capacity issues. As John had said, we're 168 beds, but we are currently under construction to increase beds because we have been at capacity for greater than 1.5 years. So finding beds in the appropriate place is definitely an opportunity in our organization. Well, what happens is the house supervisor then knows, and then she will quickly talk about staffing looks good or we're a little short here. Each department then goes through what their staffing looks like today and coming up, as well as did we have any codes? Did we have any RRTs? Have we had any falls? What are our needs today? One of the things when we get to the surgical is we will cover, do we have any new procedures? It's the first time that we've done a procedure here. Do we have any brand new physicians on staff starting today so that everybody is aware of it? As you can see, it is just a quick communication tool. They then talk about any opportunities they found. Our printer isn't working, the CPOE did not allow for this to happen, or whatever it is that is going on, each department will go through theirs. We have actually, one of the things I was really proud of is our cath lab works very closely with, of course, the critical care unit and with the emergency department. There were many times when the ICU would say, our staffing is tight today. The cath lab could say, we only have this many CAS, PCIs, or TEEs today. I have a staff person that I can send to you this afternoon. And there would be talk and sharing of staff versus what I used to call hoarding of staff. And so we would share. This is where we can talk about it. One of the interesting things that we found early is in radiology, they had a patient come into the MRI, and just before that patient got to the MRI suite, somebody noticed the O2 tank that patient was coming with. It was one of the old E-cylinder. Remember the old green that were probably taken out of buildings many, many, many years ago? There's been a sentinel event alert about it. They should have gone away. What happened in our facility was we had a vendor change with who takes care of our gases. They brought an old E-cylinder in. It didn't get noticed until it got down to radiology. We were very quickly able to get that changed, and that day do a complete sweep of the house. Do we have any others? They got on the phone with the vendor, talked to them about what they could or couldn't bring in. There was a better inspection process, but it all happened before the procedure, and it was fixed. And then that then transferred to our patient safety committee as a reminder. We watch for these. An education went out floor to floor for every staff member to be our eyes to make sure a solid green tank is never in our building. That wouldn't have happened had we not had Safety Huddle to have found out about that, because I say email is snail mail. I found out that some of our directors don't look at email for days because they have too much. Well, if we are communicating by email, we're not going to make quick changes that we need to make. If you look at this list, as John had said earlier, we did have a lot of departments that were reporting, and they would go through and say, no report, no report, no report. Well, that did become redundant. So what we did was, if you will look, there's a change between facilities and admitting. You'll see the font change that got larger and bolder. So those departments from admitting down. So admitting, environmental services, EVS, materials, medical staff, those departments do not have to report out every day unless there is a report. They do not report out. What we do is at the end, when all of the top departments have reported out, then we say, are there any other departments that have a report? And at that point, HR or medical staff or somebody can pop up. We do seem to get a lot from education and HR, but it's a good place for reminders. Competency is due, you know, time is ticking, we're down to 67% or whatever it is. So it is just a great communication tool. At the very bottom of the report, it'll say how many days since our last serious safety event, how many days, and we track that at every single meeting. And then we also have added, which is not on this form, we now add how many days since our last COTI, how many days since our last CLAPSI. That now is on the form as well as we are also tracking what our HCLAP scores for the inpatient side and our ED-SAT scores for the emergency department. This is the back page, follow-up items. Remember, we have to talk about what went wrong. So during the huddle, what we ask is, so this is what went on, who will take ownership, and then at the next huddle, we have to follow up with what happened, what did we do about it, and it's very quick. The whole thing is in 15 minutes. It is very quick. It is not the time during the huddle to solve the problems. It's the time to bring the problems to light and have it followed up on outside of the huddle. We also are very keen in our service recovery. What have we done about service recovery? Did we have any patients we need to now go back to? So we talk about service recovery. And then we're always looking at great catches. I've told you about a couple of the great catches already, but when we talk about great catches, it's those kudos. We had a nurse who was able to, actually we had a nurse who scanned the patient, scanned the medication came up and said it was this medication, but when she continued her 5 R's and looked at her label, it did not match. Went through it, did it again, it still did not match. Our electronic system scanned everything correctly, but it did not match the label. She stopped the process, called pharmacy, it got taken care of. That's a kudos. We then take that information and do two things. We put it in our Friday Mansfield Messages, which is a very quick newsletter that people can read. We put her name, that person's department, and what that great catch was. Because that's an education opportunity for others to see this is what we're all about. That's transparency, and we're trying to be proactive, not reactive. In addition then, John will go if the nurse is on duty and he'll find the nurse, and the rest of us, all of us as leaders, have now heard that person's name, whether it be someone in EVS or someone in dietary. We know what they did and who they are, and we can all go out then as leaders when we see that individual and thank them for what they did in the interest of our patient. We can thank them, and don't you think that probably goes a long ways? It does. So that's some of what we can do with that information.
You know, the last point that Donna touched on, I don't think I underestimated how powerful acknowledging great performance really can be and should be. But I I was taken aback the first few times we did what Donna just said, and I really feel like, I mean, I'm a nice guy. I mean, I love talking to people. So when I go talk to a nurse or a technician or a therapist or a physician, don't forget our physicians, y'all, okay? And say, hey, this morning at Daily Safety Huddle, Dr. So-and-so or nurse so-and-so or this technician mentioned that you did this yesterday, and I just want you to know what a difference that made. That has an impact. I believe it has an impact on that team member that is being complimented. But you know, when you do that yourself, that's a great thing to do. In whatever role you're in, you're a leader in some capacity. So I am so fulfilled when I get to do that and have something specific and really real time that we can talk to our staff about. I believe that spreads really quick throughout your organization, and I believe that's just good. That can only do good things for your organization. We've touched on some of the barriers, so I won't read through every one of these, but these are some of the things that Donna mentioned earlier that we dealt with. And you know, I don't know that they're all totally resolved after a year and a half. I think for the most part they are. You know, another meeting barrier that we feel like we had to get over, I think that was somewhat put to bed after our last Joint Commission survey. And upon the exit interview, when Joint Commission was at our hospital, we had been doing huddle, I guess at that point, only about 9 months or so.
9 months.
And the Joint Commission surveyor commented in her exit interview with all of our directors and managers. We pulled all of our directors and managers together with the Joint Commission surveyors, and they kind of debriefed us on how they felt like we did. I thought that meant I was done. I'll be quick. And they commented on the Daily Safety Huddle and how positive they thought that was, and just complimented us on a best practice. So the surveyors left, and we had a good survey. And so when the surveyors walked out the door, I got up and in kind of silly fashion, talked a little bit. We clapped for ourselves and had a little pep rally. Then I said, so Daily Huddle tomorrow morning. So see you guys in the morning at 8:30 at Daily Huddle. And whew, boy, it'd be nice to skip tomorrow, wouldn't it? And I think people were kind of looking around the room like, what's he saying? We've been doing this for 9 months, and they just complimented us, And I said something like, yeah, it's another meeting, and boy, wouldn't it be nice just to stop doing that and just take a break? And a resounding, no, what are you talking about, came around the room. And I hope they still know to this day I was joking when I said that. But that really validated, I think, for us that we've got to keep doing it. And I just realized I stole one of Donna's slides coming up, so by telling that story. Sorry about that. So redundancy with bedboard, sharing issues with all. I think we've talked about that personally I'm still pretty sensitive to a leader in our organization that reports out and says something like, let's say this is a director of a clinical department, and they say, well, we reported to IT yesterday that this wasn't working and they still haven't fixed it. There's a different way to report that. And I think sharing issues with all, if we're all gonna get comfortable with a culture of transparency, we've got to train each other, and we've got to hold our leaders accountable to share that information in a more professional way, such as, I reported yesterday this wasn't working, need to check in with IT today to make sure that it's going to get fixed. There's a difference in the way we can report that, so it's a positive report and we're not throwing people under the bus. Call-in versus attending in person. We decided to attend in person as much as we could and really make that the standard. We do have some people that call in, so it seems to help. And then leaders concerned their work hours were in question. So Donna put on this slide, that's the key is trust. I was really surprised when I heard through the grapevine as it was leading up to our first day of huddle that some folks thought, well, John just really wants to see if we're all showing up on time to work, okay? So, and I think we have an awesome culture at our hospital, so don't be surprised if those things come up, I think is the takeaway from that last point on this slide. You may have a great culture. Your employee engagement, physician engagement scores may be top decile. You still likely could encounter some of these issues if you do embark upon a daily safety huddle journey.
So as any good quality person knows that when you put a new process into place, you've got to go back and measure it to see if it is effective in doing what you need. And then you can tweak what needs to be done. That's part of that PDCA cycle. Well, at the 3-month interview, we did a Survey Monkey, and we did all of the department leaders. And then we also did any of their designees that attend Safety Huddle, because as John said, every department leader is expected to attend. The only time they cannot attend is if they're on PTO, or they can't get out of a meeting when they're off-site. Otherwise, they're expected to be in person or on the call. If they cannot, there are designees that they have assigned to attend for them, because that communication flow needs to continue. You cannot have a department left out. So this talks about the differences. The green are all the department managers and directors. The blue represents the frontline staff or the designee who attends. So when it comes to meeting the objective, that's where we had opportunity. And the opportunity was they wanted us to stay on task, do our follow-up. They didn't feel that we were consistently assigning and then going back and following up. That's where we found out also that some departments did not want to say every time no report. So we reorganized our tool to give those departments, such as the EVS, dietary, et cetera, the opportunity to only speak if they have a report. Those were the types of things that we really found we needed. But otherwise, everybody did want to continue. But I thought it was interesting that the frontline staff felt this was more effective than our own department leaders. Because I think they were just in awe of how much information they were gaining. What that told me is, as leaders, we still have opportunity with communicating all the way down. This is what happened at that 9 months. At that point, we had just undergone in June a CIHQ, not CIHQ, we had done a CIHQ survey. But then we were one of the pilots for the CMS survey, who came in with 3 surveyors for 4 days? 3 surveyors for 4 days, spent time with us looking at everything related to infection control, quality, and care management. Then we went into July having our Joint Commission survey, and we did great on all of our surveys. Safety Huddle kept coming up as one of the best practices through the surveyors. And as John had said, the team said, do not stop. And interesting, as you'll recall in the very beginning, I said there were 2 members of the C-suite who were not totally sold on this at first. During this opportunity, that individual, one of those individuals, could not have spoken more highly about the Safety Huddle and its effects. She was fully on board. The other was the CFO, and his biggest concern was the loss of productivity during that time. You know, all that money going out the door by being in another meeting. But remember, this isn't a meeting. It is a quick stand-up. Meetings are 30 minutes in my world. So this is 15 minutes, so this is not a meeting. It's a stand-up. And he realized very quickly the benefit of communication, and that open communication was actually saving him money. So he was on board with it. The other thing we started tracking is our safety events. So our serious safety events, you can see when we first started, we were only at 5 days from having a serious safety event. You can see by September, so now we're into this 10 months, and at that point, we were up to 75 days without a serious safety event. But you can see, and yes, we will still fall back and have a serious safety event. But when that gets brought up in the Safety Huddle, it's like, oh, we did, and then this is what we can do about it. We bounce back from it, and we move on. But you can see that since we have started the Safety Huddle, we have continued to have longer time frames between our serious safety events. In addition, I'm sure all of you do some type of a safety survey. The AHRQ Safety Culture Survey is out there. Many different vendors put it on. We have been doing it there for several years. I went back and did our results from 12 and then again in 13 and compared them. Once we had been doing this for a year, we moved from the 75th percentile to the 90th percentile in management support for patient safety. We moved from the 75th to the 90th for our organization's continuous learning. Teamwork across the units moved to the 90th percentile. Non-punitive culture moved from the median. It was at the 50th. It moved from the median to the 90th percentile. And then again, our patient safety grade, we received an 85% from our staff versus the benchmark of 76%. I think that right there speaks volume for the effectiveness of a safety huddle. We're going to go ahead and give you just a quick snip so that you can hear what one sounds like. We do open our huddle, by the way, because we are a Christian-based organization. We open it with a prayer every time, and then we start right into house supervision and just round robin it. So if we could cue that up.
Good morning. Everybody. All right, we'll get rolling. Woo! It's Wednesday, right? Deep breath.
Shelley's not here with her sign.
No. She is here, though. I've seen her. All right. House supervision.
All right, currently there's 3 patients in the ER. One of those is a hold and one is flying out. ICU has 14. Labor and delivery, I left my sheet, I wrote it all out, I left my sheet of paper. Labor and delivery has 6 laborers and 2 aunties. Special care had 8 babies this morning. Special care, thank you. Had 8 babies, sorry. FCC has 13 adults, 11 babies. Third floor is at 30 with 1 surgery to come. Postpartum also has a surgery to come. Fourth floor is at 29 with full PCIs, and fifth floor is at 31. And there were 2 RRTs yesterday on 5, and they both went to the unit. One of them stayed for observation for part of the day, and then came back out. And there's no tally boxes again this morning.
The one patient holding for tele. Okay. All right. Emergency department.
Morning.
Morning.
128 yesterday with 1 LWAT. Computer issues. Well, the times were good yesterday.
There you go.
All green. I was door to floor, door to discharge, and door to dock for all great.
Right. All right. Thank you, Sean. ICU.
We're good today. I was report today. Yesterday was a pretty wild day, but things went really fairly smoothly. 6 in, 6 out with the ICU, 2 RRTs, an emergency intubation up on the floor. But everything went well.
Right.
So it's an indication that we can really do well even when we're jammed up.
Mm-hmm.
Good. Thank you, Tim. 3 East.
Good morning.
Good morning.
Some of you saw the email that I sent out on Monday, I believe. Kudos to Dr. Reesner. When I was rounding on Monday, one of our patients just raved about Dr. Reesner and the great care that she provided and the great communication that she gave to the patient and the family. So you see Dr. Reesner did a great job. And then,
Thanks for emailing that.
Sure. And then we received a patient from the ED where the med rec was recalled from the previous admission, and the hospitalist ordered the patient's home meds based on that med rec.
All right. Anything else?
Sean, would you follow that up? Thank you.
We can stop it there if y'all would like. So that gives you just a brief sample, and it's funny, that recording is from probably about a year ago. So as I listen to us, I'm excited to say that I think that was an effective huddle, but I think we're even better now. We've had another year under our belt. I get really chatty, so I'm not quite as chatty as I am on that recording now, I don't think. So it's been such a pleasure to get to visit with y'all. We may have a minute or so for any questions, or Donna and I We'll be around during the break and would love to answer any questions that you have. You know, a big help to us was we needed a partner to help us feel good about how to start Huddle when we embarked upon our journey. And so if we can be of any help, we would love to be of assistance to you and your organization as you evaluate huddles for your organization.
Any questions?
Thank y'all.
Thank you.
Thank you very much. Great to see you guys. Thank you, Doctor. It was very good to hear you. It was excellent. Thanks a lot. Have a good one.